either. Don't worry, more of us are here. Okay. Then Josh. That's Josh. Kai couldn't make it. Bryce could not make it. Ren is here. Andrew, not coming. Christian. I'm Nick. And Michael. Brad's not coming. Jeannie. Angel's coming later. And no Lauren today. And then Jordan's right here. He just got his wisdoms out, so that's his picture right after. And then Doris is also coming today. Okay, so let's go ahead and get started. We're going to run this kind of like a Socrative style, kind of like what Dr. Marikawa and Dr. Alarcon do, except this is just something a little different. So if you guys can just take a moment to scan. She's coming late. Yeah, Doris. Oh, okay, nice.
Less than a minute? Okay. Yeah.
We'll send it out.
Yeah, and there's a lot of questions today, so we might not get through all of them, but yeah, we'll send it out afterwards. And because we might not be able to get through everything, try to do the answers as fast as possible, just to make sure we get through as much as we can today. Doris.
You good?
Okay.
There's 73.
We have 73 people.
Is anyone still trying to get in? We good? Yeah.
We can see the results page. We don't have like an option to answer right now. Oh yeah, it's closed, that's why.
Alrighty. Okay,
Good.
so let's go ahead and get started.
Okay, so starting off with case 1, essay. Where's the thing? All right, Jeannie is a 23-year-old Olympian who presents to her primary care physician complaining of a sore throat and fever for the past week. Upon physical exam, the doctor notes pharyngitis, enlarged lymph nodes, the posterior aspect of her neck, and splenomegaly. When questioned further, she admits that she recently started a new relationship just 2 weeks prior to the onset of her symptoms. What is the most likely diagnosis? Once we get to about like 60 or 70 responses, we'll close it off and get to the answer. Okay, changing it in 3, 2, 1, and EBV. Right, so Epstein-Barr virus associated with mononucleosis. Some of the key features from this prompt, not just the sore throat and fever, because that's kind of non-specific, but the posterior aspects having the lymphadenopathy as well as the splenomegaly. If you're thinking more on the strep end, you might look for like anterior cervical lymphadenopathy, as well as those other key signs like the tonsillary exudates, fever, as well as the no cough, right? Thinking about your Centaur criteria. Influenza, other things, more abrupt with your fever, dry cough, COVID, adenovirus. That's pretty much it for this one. And yeah, also I guess the fact that she started a new relationship recently can kind of hint towards mononucleosis diagnosis, but other key signs with physical exam is going to be what will lead you to that. Okay. I forget who's next. Oh, sorry. Oh, whoa.
This is just a table. I don't know
Like
where.
DDX.
Yeah, so just some DDXs, and then you can just kind of go through this when we send you the slides.
Okay, you guys can read this. It looks like you guys need to review your microbiology.
Red.
You have no clue.
Mention that.
Are you feeling okay?
That's good.
Okay. Correct answer is D. So catalase is going to differentiate between strep and staph, right? We didn't learn about staph yet, but just know that it'll be catalase negative. We know that strep pyogenes is, well, there's 3 types of hemolysis, and specifically it'll be beta hemolytic. Bacitracin is how you differentiate between different types of beta hemolytic strep. So in this case, pyogenes is sensitive. I would review this like algorithm table. You can just search it up. There's lots of different ones. The main important part is going to be under strep, right? Just know how to differentiate between pyogenes and agalactiae because they might ask about bacitracin or like pure status.
All right, next question. A 16-year-old girl named Nikki arrives at Mililani Urgent Care with the chief complaint of pharyngitis and fever. Her physical is positive for anterior cervical lymphadenopathy and tonsillar exudates that are white and foul-smelling. Her rapid strep returns positive and monospot is negative and confirms strep pyogenes infection. Which of the following is true about the virulence factors for S. pyogenes? I hope so. Are we good? All right, okay. So correct, the answer is C. Streptokinase is one of the virulence factors and catalyzes conversion of plasminogen to plasmin, which breaks down clots. And these are just some of the other virulence factors for other bugs as well. Okay, and then we just have a table also, as well as some entries from first aid, which I definitely recommend you guys review also. Okay, Josh.
Kind of long. During one of her follow-ups after her diagnosis of strep throat, you counsel her regarding the most common group A strep complications. She expresses worry that her friend was diagnosed with a skin infection caused by strep. She developed kidney issues and ended up in the hospital a couple of weeks after her infection resolved. You explained to her that
Let's do 10 more seconds. 5, 4, 3, 2, and 1.
okay, yeah, so while she's at risk of developing the same complications, probability is low. So PSGN is a type 3 hypersensitivity following both either skin infection or strep throat. Because she had strep throat, she's also at risk for PSGN along with rheumatic fever. Should be counseled to look out for post-strep complications, including rheumatic fever and PSGN. Symptoms of the post-streptococcal glomerulonephritis include cola-colored urine and facial edema, whereas rheumatic fever causes symptoms according to the Jones criteria. Can anyone tell me what Jones stands for? Okay, great job.
Okay, and then you guys can review all the other complications later. I didn't know that. Okay, Jeannie.
Okay, so Jushi is a 22-year-old male who comes in with 3-day history of sore throat, fever, and difficulty swallowing. He has a fever, pharyngeal erythema, and tonsillar enlargement with exudates. He has tender anterior cervical lymphadenopathy, and his Centaur criteria is 4. So which of the following is the most appropriate next step in management? Okay, so a lot of you said empirical treatment with antibiotics without further testing, but because there is like a rapid antigen testing that can be done in like less than 10 minutes, you should always do the rapid antigen testing because it can quickly confirm your diagnosis. You don't want to automatically treat someone without confirmation, especially for strep, which has like high antibiotic resistance. So if it's available, you should do it. And then depending on whether those results are positive or negative, you can also send a confirmatory like throat culture. It just takes a little while. So I know there's some like contradictions in like different guidelines. So like I think the AFP says that if it's like a 4 or more, then it can be considered, like empirical treatment can be considered. And then like the other guideline says like it shouldn't, like you shouldn't do empirical treatment. But like a good like way of thinking that some like of our physicians have taught us is like no meat, no treat. So if you don't do a biopsy, if you don't get the test done, then you shouldn't treat it because then you might be over treating. So yeah, no meat, no treat.
Tissue is the issue.
Tissue is the issue. And then know your Centaur criteria. So like what counts. So like the exudates, anterior cervical, lymphadenopathy, fever, and no cough. And then also like the modified one is like considering age. So if they're less than 15 years old, that adds another point. And if they're older, then it's less likely to be strep.
Okay, lymphocytes can often be found in lymph nodes. Cells that are responsible for producing antibodies are found in which part of a lymph node? Wait, what are they saying?
No, they had
It's because it was an essay, right? Did you check for...
Okay.
Okay, correct answer is A. So I think lymph node anatomy came up in the essay Saipa case, so you should kind of know how they work. B cells and T cells are matured in different areas, so matching up where the correct zone is to where like the actual part on the lymph node is going to be important. So I would review just like a general picture of what it looks like and then where all the zones are. Oh, this is me too. Bradson, that's him on the left, is a 9-year-old boy and presents to the peds clinic with sore throat, fever, and swollen cervical lymph nodes. Rapid antigen detection test confirms presence of group A strep. Patient is prescribed penicillin V. Despite the long history of penicillin use against gas, resistance to this antibiotic is extremely rare. Which of the following best explains why Streptococcus pyogenes has not developed significant resistance to penicillin? Five, 4, 3, 2, 1. It's D. It's okay, you guys can still pass. It's only 65%. So yeah, this is another micro-specific question about strep pyogenes. You're gonna have like clinical questions on pharyngitis, but also knowing things about the bug and like its treatment is gonna be important.
And then most of these other answers would actually are like describing resistance to penicillin, but the question is asking why it has not developed resistance to penicillin.
Yeah. Those are different bugs, which you'll learn about later. Oh, and then more about penicillin. You should all know how it works.
All right. JC, a 24-year-old softball coach, was recommended by one of her players to consider trying copious amounts of kava boba tea with extra kava for her headaches. She's already taking daily acetaminophen for her pain. Luckily, her friends Dr. Yang and Dr. Loy, oh, that's me, advised her against taking this combo of compounds because of the potential for... How are you doing? Okay. All right, yes, correct. So the answer is hepatotoxicity. So acetaminophen and kava are both known to cause hepatotoxicity. So if you take both of them, which you shouldn't, yeah, I would recommend against that. Yeah, it'll kill your liver. Okay. And then I think you probably have to know the MOA of acetaminophen. So this is just the first aid entries on that. And a little bit about kava. There are culturally perceived benefits, which can reduce inflammation. It acts as an anesthetic, a relaxant, although, of course, and it is contraindicated when you have liver dysfunction. Okay. Non-opioid, fermented, non-alcoholic. There's a card. Okay, next, Julia Huang. All right, Doris.
Okay. What are the tissues in order that a thin piece of glass will touch if it penetrates your lung directly above your third rib? Also, is there any risk for intercostal band damage?
Oh, and just in case, VAN is vein, artery, nerve.
Okay. Okay. Correct layer is skin, muscle, parietal, and then visceral, and then lung tissue. So what VAN is vein, artery, nerve. It's located above, below. Sorry. So if you're stabbed above the rib, you will miss the VAN, and you won't be. Can you go to the next slide?
Oh, yes.
This is a good picture. Also probably good to know the intercostal layers, so external, internal, innermost. But yeah, you can see where he's hovering. VAN is over there. There are collateral branches, but those aren't as big. So main thing is if you pierce below, it'll hit the VAN.
That's why we need you a chest tube. You go above the rim, right above the rim.
Okay, Nick, a 25-year-old spy, is stabbed by his nemesis Michael while on a mission, resulting in a puncture wound to his right chest wall. This results in an open pneumothorax. Which statement is most accurate regarding this situation? How are we doing? Good. Good.
5, 4, 3, 2, 1.
All right, yeah, so the answer is B. So intrapleural pressure is equal to atmospheric pressure. So because this is an open pneumothorax, that means the pleural space is otherwise exposed to the atmosphere. So the pressure in the pleura is equal to the atmosphere, which is also equal to the alveoli, which will then lead to the collapse of the lungs. You guys got a lecture from Dr. Higa about this? You guys did? Okay, perfect. Great. And then this is just some pictures on kind of how the lung works in terms of pneumothorax. So this is the open pneumothorax right over here, where basically we're exposed to the outside, where the pressures equalize otherwise. Okay, Jeannie. What?
ABG or AVG? Okay. That was this morning. Okay, so her pH is 7.3, PCO2 is 30, PO2 is 73, bicarb is 14, and SaO2 is 88. So which of the following is the best interpretation of these ABG results? No, it's from the internet. Would it have been better if it's someone we know? Jewel. Mixed answers here. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay. Wow, you guys were pretty split on this one. So it's metabolic acidosis with respiratory compensation. So it's basically,
Sufficient respiratory compensation. Sufficient.
what did I say?
You said with respiratory.
Oh, with sufficient respiratory compensation. So she's compensated. So this is what Julia had, right? She had metabolic acidosis with sufficient compensation. So we know that she's acidotic, right? Because her pH is low. So it's not going to be any of the alkalosis. And then we know that, oh yeah, CO2 is also low. So we know that Rome, right? Respiratory is opposite and metabolic is equal. So if you look at pH and pH is down, if the carbon dioxide or the bicarb level is also down, that means they're going in the same direction, which means it's metabolic. If pH is down, but CO2 or bicarb is up, so they're going in opposite directions, it's probably respiratory. So that's how we know if it's metabolic or respiratory. And then we have to check if they're appropriately compensated in metabolic acidosis. So that's when we use Winter's formula, right? So the 1.5 times the bicarb, so this is the measured bicarb, plus 8 plus or minus 2, so it's a range, right? So if we did her bicarb was 14, so we plug that in, the range would be 27 to 31 is what we expect. And so the actual measured CO2 was 30, so it's in that range, right? So that means that they're properly compensated. So if their actual carbon dioxide level was maybe 33, then that means that it's higher than what we would expect, higher than the range. So that means there is also like concurrent respiratory acidosis. And then the opposite would be true. So if it was like 25 or 26, then there would also be concurrent respiratory alkalosis. And so this is a really important concept for you guys to know, at least the Rome, so how to identify respiratory versus metabolic, and Winter's formula to make sure that they're properly compensated in metabolic acidosis. So Winter's formula is only for metabolic acidosis that it can be used. So this is something that's really important, and it'll come back again and again in MD2. So it's good to have a good understanding now.
Andrew, a 24-year-old man, is rushed into the ER by paramedics after he was hit by a car while riding his bike to school. You're the first to meet the paramedics. You notice that he's not moving, so you check his airway for any obstruction. After clearing his airway, you intubate and ventilate the patient and start to notice unilateral chest wall movement upon inspiration and expiration. What's the next step in assessment?
Okay, 5, 4, 3, 2, 1.
Okay, so check his pulse and blood pressure, because like in the order of trauma assessment, the A, B, C, D, E, out of all the options, this is assessing circulation, which would come first. The other options either come later or just not part of like your routine trauma assessment. And then this is more things. So A, B, C, D, E on the left, and then. Oh, okay. Primary and secondary assessment. Thank you, Jeannie.
Okay. Angel, a previously healthy 36-year-old woman comes to the physician because of a 2-day history of pain and urination. Vitals are within normal limits. Physical exam shows suprapubic tenderness. Urinalysis shows neutrophils, positive nitrite. Urine is gram-neg, oxidase neg, rods. They form greenish colonies on EMB agar. What virulence factor is at risk? What is the virulence factor of this bug, basically?
Thank you.
Well, you guessed it correctly.
You're right, bro.
You were close, you got in blood.
Five, 4, 3. You guys are changing your answer. 2, 1. Okay.
Sexually active females.
Okay, answer C. So the bacteria is UPEC, it's E. coli. Yeah, that's how it like adheres to like the urothelium and like travels up. Some of the other virulence factors are just like bugs that you might need to know. So like strep, gonorrhea, pseudomonas, stuff like that. Oh, some stuff about E. coli. I'm not going to read it, but it would be good to know all of this stuff. Yeah.
What did
Oh, uh-oh.
Okay.
Oh, there we go.
Oh, okay. Lauren, a 50-year-old woman, is admitted to the emergency department after a severe gastrointestinal bleed. She presents with hypotension, blood pressure 85/50, tachycardia, and signs of confusion. Her laboratory tests show elevated serum creatinine and blood urine nitrogen levels. Urinalysis reveal a renal tubular epithelial cells and muddy brown casts, indicative of ATN. Given her condition, which of the following physiological changes related to an MRS is most likely contribute to a kidney injury? Okay, that was a long one. Sorry.
They're stumped.
It's a long question.
Well, at least I've said it. It's a toughie.
It is a toughie. Okay, 10 more seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. All right, not too bad. Not too bad.
Yeah.
That's okay. Okay, so it's C. The increased release of renin in response to reduced renal perfusion pressure. So if you guys recall, when you have, in this case, decreased volume, so it's a pre-renal AKI, and so you're going to have less blood flow overall, so your macula densa and the juxtaglomerular cells are releasing renin. And so in response to the increased renin, you're having more angiotensin II, and it's going to result in like efferent and afferent arterial vasoconstriction. So it's actually going to damage the kidney more because you're reducing more renal blood flow. We can go to the next page, sorry.
Wait, explain the other
Oh,
one.
sorry. The other wrong answers. The other ones are wrong. Angiotensin II decreases renal perfusion. For B, RAS will is increasing aldosterone with RAS. For D, it helps initially to maintain blood pressure, but which we'll go over later with increased angiotensin II, it causes overall decrease in GFR. And then for E, RAS should be activated, levels should be elevated as well. Okay, so on this page, this is a lot of stuff. But overall, like you see like the macula densa here on the top left. Sorry. So over here, it's like detecting like blood flow and everything, and so it's going to be responsible for releasing renin. So the juxtaglomerular cells are releasing renin in response to these RAS activators, right? So decreased blood pressure, decreased sodium chloride delivery, increased sympathetic tone. That's releasing angiotensin II, and so you're going to have these downstream effects of increased reabsorption, aldosterone secretion, ADH, as well as vasoconstriction. And so at low levels, angiotensin II is going to decrease, low levels, angiotensin II will constrict the efferent arteriole, so you're increasing the GFR, right? If you're like pinching a balloon at one end and allowing more to flow into the nephron. But if you have like high levels of angiotensin II, it actually constricts both. And so that's where you have overall decreased GFR, and so it's going to damage your kidneys even more because you're getting less flow and everything to that. There's like a little more detail to it, but that's essentially like the concept that you should know in order to get this question. It was a little tough, but yeah. Okay.
Okay, Lauren is a Japanese Chinese American female who tries alcohol for the first time on her 21st. She notices her face and neck got red after a few drinks, which is called Asian glow. She found that Asian glow is caused by an enzyme deficiency in the alcohol metabolism pathway, which leads to a buildup of acetaldehyde. So which enzyme is impacted and where is it found?
You guys are fast. You guys know your alcohol. You guys gotta drink more. Yeah. You should say it. Well, who's reading this? Yeah, sure.
No. Stop.
Especially.
Yeah, I think he started that.
5, 4, 3, 2, 1. So it is acetaldehyde dehydrogenase, but it is in the mitochondria. Can you go to the next slide? So this is like the alcohol metabolism pathway. It's basically just 2 steps. So it goes from ethanol, which is like the alcohol that we drink, and then it gets converted to acetaldehyde by alcohol dehydrogenase. And then that acetaldehyde gets turned into acetate by acetaldehyde dehydrogenase in the mitochondria. I think the only other important thing to know is that alcohol metabolism uses NAD+, and then it converts it to NADH. So it is like a form of energy production. But alcohol dehydrogenase is in the cytoplasm, and then acetaldehyde dehydrogenase is in the mitochondria.
Hey, Jordu. All right, Jordan.
Which of the following statements is false about Mycobacterium leprae? And then choose from those.
Armadillo.
Thank you.
I don't know if it's a 9-banded. I just looked up armadillo.
Is that how
Not on the midterm.
Yeah, they all have sunglasses too.
And
All right, 5, 4, 3, 2, 1. Yeah. All right. So
It was what is false.
yeah, that's what's false because it grows better at cooler temperatures.
Which is why.
Which is why it's true.
What?
Okay. Oh yeah, but yeah, that's why it's concentrated in the skin, superficial nerves, and extremities. So like colder parts of your bodies, right? Like you don't see it in like your armpits and stuff. Yeah. Yeah.
Yeah.
All right, moving on.
Got it. All right. Oh yeah.
JC. Michael, what slide number are we on?
61.
Okay, we gotta speed it up. Okay.
All right, besties. Sherry, a 32-year-old armadillo caretaker with a history of type 2 diabetes, presents to her PCP with numbness and tingling for 3 months. Sensation is localized to a few patches of her skin, which are characterized by hair loss and hypopigmentation. Skin smear shows acid-fast bacilli on Zeal-Nielsen stain. A Lepperman test returns positive. What is the underlying pathophys of the condition? And you guys can read the rest, I'm sure. Okay, let's do 5, 4, 3. Who's counting down?
5, 4.
All right.
Oh,
Read the
I already
answer.
pressed it. I already pressed it. Sorry.
So yes, this is a tuberculoid type presentation with the hair loss and the hypopigmentation in the patches. This is in contrast to the lepromatous type, which would have like the lion facies and is usually a lot worse. Tuberculoid type is Th1, whereas lepromatous is Th2. And so just remember that the strong immunity is like a lot more contained than the weak ones. This is not diabetic neuropathy because the sensation is only in the patches. The sensation loss is only in the patches, not like her feet. And everything else doesn't really relate to what we're talking about. So yeah, here's figure A would show more of the lepromatous one. And then just like general information about leprosy, which again, not gonna read, but would be good to know.
Oh, this one doesn't have answers.
Oh yeah.
So this one doesn't have anything on the poll. So just tell me, what are the 4 R's of red pharma? Anybody?
Rapid resistance.
If what?
Body fluid.
Okay. What's up? Okay.
Okay, cool. So you guys got it correct. So RNA polymerase inhibitor, particularly the DNA-dependent RNA polymerase is the what it inhibits. Also, if someone is on rifampin, they may expect red-orange body fluids, either tears or pee. It ramps up to 450. It induces it. So it has some drug interactions with those who interact with that CYP450 protein. And then there's also rapid resistance if it's used alone, which is why it's often paired up with other drugs, such as dapsone and clofazimine. So make sure that you understand the mechanism of actions for all 3 of these drugs, and then why they're used together.
All right. Ren, a microbiome lab tech, is performing an acid-fast stain on a sputum sample from a patient suspected of having tuberculosis. The acid-fast stain is a critical diagnostic tool for identifying certain bacteria. Which of the following best explains the mechanism underlying the acid-fast staining procedure? 3, 2, 1. Good. All right.
Good job, guys.
Yeah, you guys did a good job on that one, so I won't explain too much. But yeah, mycolic acid in the cell wall, right? The first option talks about peptidoglycan. What stain does that? Gram. Yeah. Okay. Great. Good job.
Okay. Christian is a high school athlete who presents to your clinic with peeling skin and erythema on the plantar aspects of his feet bilaterally, especially between his toes. Potassium hydroxide preparation of skin scrapings reveal the picture to the right. What is the mechanism of action for the drug that you would prescribe for him to him for his condition?
Is he doing yoga?
That was in front of Body Balance when they were still building it.
Five, four, three, two, one.
So for this question, okay guys, listen up. So for this question, you have to identify what the organism is and like what kind of drug that you're prescribing. You can see the hyphae there, which is indicative of Tinea pedis or trichophyton species, which is commonly what causes Tinea pedis. And then you would prescribe azoles to treat this condition. And azoles would target the conversion of lanosterol to ergosterol. And then you want to pay attention to where it's located. So it's going to be located in the cell membrane. A lot of people will mix it up with the cell wall, so just keep that in mind that it is located in the cell membrane. And yeah, this shows the whole sequence from lanosterol to ergosterol. And you can see like the different types of antifungal therapies. Focus on the ergosterol synthesis part, so you can see all of the different azoles there.
We can speed it up.
And it's going to be producing, or it's going to prevent the production of ergosterol, which is located in the cell membrane.
Okay, moving on. Okay.
Oh, okay. Michael is a 36-year-old male who presents to the clinic with persistent abdominal pain and diarrhea, which is normal for him. He reported a few weeks ago after the trip to the Philippines. He was referred to get a colonoscopy where it was found a large burden of trichuria, which in the following describes the most likely way he acquired this infection.
Wow, you spent a lot of time on this, Jeannie.
Huh?
You spent a lot of time on this.
The memes, yeah. Okay.
Okay.
5. This one should be easy. 5, 4,
3, 2, 1. Okay.
2, 1. Okay. So it's fecal oral like transmission. So consumption of contaminated foods and vegetables a lot of the time. Yeah, the other ones you don't really need to know, but they're just other like GI infections. So just know it's fecal oral, as is all of them basically. And then this is just the life cycle. So you know, eggs to cysts to whatever.
Which of the following statements is true about COFA?
Was this a case point?
Wait, did you guys talk about
Yeah. Was this a case point for you guys? It wasn't the case? Okay.
I told my PBL group to do it.
And we're running out of time, so we're going to speed it up to like 20, 30 seconds per question.
Yep.
So
3, 2, 1.
Okay.
It's all of them.
yeah.
You guys did
Okay.
well.
Okay, you can read this one for the review. Okay, moving on. Harry Souza. JC.
So here we have our dear friend Courtney, a 56-year-old woman with hypertension osteoporosis. She's been prescribed hydrochlorothiazide. Which labs are you going to monitor to avoid cardiac problems? Okay, 5, 4, 3, 2, 1. So those of you that said serum calcium and potassium, you would be correct. The reason for that is because thiazide decreases the renal excretion of calcium, which is why we're giving it for the osteoporosis, but it also promotes the excretion of potassium, which can lead to hypokalemia, and then hyperkalemia with prolonged use or other meds. Potassium is really important for cardiac conduction, which you'll learn a lot about in MD2, and so either way, hypo or hyper can cause a lot of problems, so you want to make sure that you don't have those problems, basically. Calcium can also cause problems, but potassium is really the main one. So it's all right. Oh, there's a mechanism of thiazides. They inhibit sodium chloride reabsorption in the early distal convoluted tubule.
Well, then you guys can remember the hypergluc
Oh yeah, hypergluc.
mnemonic right here. So hypergluc. Okay.
So Jordan has chickenpox, has had chickenpox as a child and is concerned about his risk of developing shingles. Dr. Omori explains that the Shingrix vaccine can significantly reduce this risk. Which of the following best explains the mechanism by which the herpes zoster vaccine reduces the incidence of shingles in this patient? And how does this compare to the mechanisms of the varicella vaccine in preventing chickenpox?
Oh wait, is it not letting you? SARS. My bad.
Five, 3, 2, 1. I put a pause.
Okay, so yeah, so for the herpes zoster vaccine, it boosts the varicella zoster virus specific cellular immunity, and then that decreases by age. The other ones aren't correct because whether it's boosting cellular immunity versus like humoral immunity, and then also like whether it's preventing reactivation or like preventing shingles in the first place. So.
Lyd, a 28-year-old woman, presents to the clinic with a painful vesicular rash and a dermatomal distribution on her right thorax. She reports a history of chickenpox as a child. Upon examination, the physician suspects reactivation of VZV. Which of the following best describes the pathogenesis of reactivation?
Okay, 3, 2, 1. Okay.
Yeah, so varicella becomes latent in the dorsal root ganglia, and then later in life, like especially with older patients who might be immunosuppressed or due to like chronic stress, can reactivate herpes zoster or shingles, and it'll travel along the sensory nerve fibers to the skin, causing the painful vesicular rash, and then it follows the dermatome. That's why it has that like characteristic rash appearance. Yeah.
Yeah. Which characteristic which correctly describes varicella zoster? Alright, so double-stranded DNA, icosahedral. Yeah, this one is pretty much just memorization. But one nice thing about it is that if you learn that all herpes viruses are double-stranded DNA with envelopes and icosahedral symmetry, and you know that VZV is a herpes virus, then you know all the other herpes viruses too. So I would memorize that for the future. Anything else? Oh. There's a lot of other facts about it. Yeah, I would definitely know that for the exam, but I don't think that me reading them to you will help, so.
So yeah, I think we have a few more questions. Okay, let's continue.
Okay, Bryce, a 6-year-old child presents with a rash that is on the face, trunk, and extremities. The rash consists of vesicles on an erythematous base. The child also reports itching. The parents mentioned that no other children have these conditions, and then they recently switched soap brands. So what is the most likely diagnosis?
Okay.
5, 4, 3, 2, 1.
Okay, and it's contact dermatitis. The big clue here is switching the soap brands, and no other children have similar symptoms. So it's most likely contact dermatitis due to the soap.
Groob, a 65-year-old man, has a 3-year history of osteoarthritis in his knees. He's a former marathon runner and still goes jogging 3 times a week. Which of the following is not a risk factor for osteoarthritis? Five, 4, 3, 2, 1. Yeah, so increased strength in quadricep muscles. Everything else is a risk factor. Age, joint malalignment, stuff like that. Next slide. And then here's osteoarthritis. Those are like your Heberden's Bouchard's nodes. So H, you can think high, that's the distal, and then B, you can think below, that's your proximal. Or you can just think like alphabetical order from proximal to distal. Heberden Bouchard's, and then that's your like pathophys pretty much for osteoarthritis.
Kai, a 73-year-old man, presents with 2-year history of progressive memory loss. A recent left hip fracture prevents him from showering independently, making him feel down and like a burden to his daughter. Which of the following tests will help to assess his memory impairment? Okay, good job. So the mini cog test is for cognitive function and memory. All of the other ones you should be doing too in this case, but we were specifically asking for his like cognitive ability and his memory. So PHQ is for like depression and mood. His ADLs and IADL assessment would be important for, you know, independent living. And then gait assessment because of his broken or his like hip fracture to assess like his mobility. So you don't have to know all of them, I think. Know what they're for and just like generally like how they assess it. I would probably know at least the ADLs. I think that's like easy enough to remember the 6 basic ADLs. So I would probably know that one more, a little bit more than like PHQ and mini-cog. And then this is the last one.
Which is not a consequence of ageism. This one should be pretty self.
3, 2,
3, 2, 1.
1.
There's only like 40 of them.
I'm sorry.
Okay. Now there's like 60 of them.
Okay, good.
Yeah, anyone who couldn't guess that based on just kind of reading it.
Whoa!
I'm a slow reader.
Okay, but seriously though, they do get less pain medications for the same medical conditions, and they do have a lot of times delayed diagnoses and longer hospital stays, simply because people assume, oh, they're old, they're going to have such and such problem. It's probably not a real thing, or it's a factor of aging, or they don't get out of the hospital quickly enough because people think they're old and they can't take
So the and we should be screening them more essentially instead of wasting. We're not wasting money. We should be screening them more.
All right, so that's it. Just if you have any questions, we'll be around for a few moments. So just feel free to ask us. Good luck, and then make sure you celebrate after your midterm. Okay, good luck, guys.
Yeah, practice